Well, we'll go ahead and just get started with introductions. So hi everyone, my name is Lena. I am one of the mental health specialists for the provider to provider consultation line, and I'll be coordinating today's perinatal echo session. This is our final session of the second series of the PPCL perinatal mental health echo. All right, that was a mouthful.
Mhm.
So we'll go ahead and get started. Thanks everyone for joining us today. Um, just want to go over a few housekeeping rules and just look at our agenda real quick. So today we will start off with introductions and we'll try our best to adhere to this schedule. I'll tell you guys a little bit about PPCL in just a minute. And after that, Dr. Olivier will lead us in introductions. After those intros, we'll go ahead and transition to our didactic. That'll be presented by Dr. Bruno. And then we will move on to our case presentation portion of the session, which will actually be a group discussion today on any current or past cases that participants may have. So we encourage folks to think about any cases that you may want to discuss with the group and have our hub team of experts provide feedback or support on. And after we go through our case presentation discussion, we'll wrap up with announcements and then we'll go ahead and close out the session for today. Um, but just to tell you guys a little bit about PPCL, if you're not familiar, we are a no-cost mental health consultation program available to pediatric and perinatal providers across the state of Louisiana. Um, we provide support to providers that are working with patients ages 0 to 21 or women in the perinatal period. You can contact us Monday to Friday, 8 to 4:30, or submit an online consult request for support. We have licensed mental health professionals, and we also have perinatal psychiatrists and child and adolescent psychiatrists and addiction medicine specialists that are here to support you if there are questions about medication management or diagnosing. And we also provide support around resource and referral information. And we also offer trainings such as these. So just to let you guys know, if you want any program updates or want to register, just scan that QR code and you'll begin to get correspondence from us. But I'll go ahead and pass it on to Dr. Olivier. She's our facilitator for today, and she'll go ahead and lead us in introductions.
Hello, everybody. Thank you for joining us again today. I'm Dr. Olivier. I'm a psychiatrist in Lafayette, Louisiana at my private practice, Bloom Mental Wellness. I'm also a child, adolescent, adult, and perinatal psychiatrist. Um, we have, for each of these sessions, as you know, we have a team of hub experts that join us each session, and we represent different mental health specialties. And so I'm representing psychiatry. We also have another psychiatrist on our team, Dr. Finelli. You want to introduce yourself?
Sure. Thanks, Dr. Olivier. Juliana Finelli. I'm a psychiatrist at Tulane. My clinical focus is perinatal psychiatry and infant and early childhood psychiatry. And I serve as medical advisor for PPCL's perinatal psychiatric consultation and as a psychiatric consultant, and benefited from consultation from Dr. Bruno in the early years of our program when we were starting our PPCL perinatal program. So we're really delighted to have her here.
Yes, we are.
Thanks,
Thank you,
Jill.
Dr. Finelli. And we also have our team of social workers. Jody West, you'll see on the call. She's in the background today. Lena Regette also.
Doc Lena Riggett. I'm one of the LCSWs and mental health specialist for PPCL and a member of the hub team.
Thanks, Lena. And Jody is also our program coordinator. And Katie Abear.
Thanks, Dr. Olivier. I am Katie Abear, and I am in private practice in Lafayette as well at Bloom Mental Wellness. I'm a licensed clinical social worker, and my practice is perinatal focused. Thanks for having me.
Thanks, Katie. And also Dr. Zena representing psychology and nursing for us on our hub team.
Hi, everybody. I'm sorry, running a tad late. It was traffic. But anyway, I'm, as Dr. Olivier said, a nurse and a psychologist. I work at Department of Psychiatry at Tulane. And I'm having a lot of fun working on the hub team for this. And I'm actually delighted to see Dr. Bruno with us today. We've done stuff together for a long time, so it's great to see her.
Thank you. Good to see you.
Yeah, we are very excited to have Dr. Bruno presenting today on the effect of hormones in the perinatal period. So, Dr. Bruno, if you want to go ahead and introduce yourself and go ahead and take it away.
Okay, Rennie Bruno here. Been practicing for about 30 years. Started in child psychiatry and sort of walked my way through the developmental cycle of women to perinatal, and have been in many settings with Dr. Zena and Dr. Finelli. And now, just to keep it short, I am in part-time private practice. After I haven't been on the staff at Women's for about 28 years, and we'll just jump in. I'm grateful always to be invited and for you all to be here, so many of you on a holiday week. So let's get started. And Lena, could you advance to the next slide? So let's start with the acknowledgement that understanding a woman's brain is necessary to inform us on things like prevention, early intervention, and treatment of perinatal mood and anxiety disorders. And this requires an understanding of what we call the biology, which includes, as Dr. Howard says here, genetics, reproductive hormones, and reproductive events and comorbid disease states. But for the purposes of our discussion today, we're going to focus exclusively on reproductive hormones and their impact on perinatal mental health. Next slide, please. We're going to start with some basics, especially for those of you who are non-medical care providers. Hormones, I'm going to define that for you a little basically. Hormones are, although we know what they are in general, they are chemical messengers produced by glands in the body that travel through the bloodstream to help control and regulate the function of distant organs or cells. There are complex communication pathways among the brain, the thyroid, the adrenals, and reproductive organs. And these all must be considered in the biology of perinatal mental health. The terms on the left in this slide are all synonymous by and large, but for the purposes of today, I'm going to use the term reproductive hormones to refer to all of these. Reproductive hormones, as those listed on the right, are considered what we call neuromodulatory, meaning they circulate to the brain and influence neuronal activity and thus influence our emotions and emotional regulation and emotional expression. In reference to perinatal mental health, we're very familiar with the key players, right? Estrogen, progesterone, and oxytocin. Estrogen and progesterone are made primarily in the ovaries and to some degree peripheral tissue like body fat. Who knew, you know? And progesterone also in the ovaries, and then oxytocin in the hypothalamic pituitary axis. And of course, then there's the thyroid hormone, which comes from the thyroid gland. Before we delve into the clinical aspects of estrogen and progesterone, and in particular, the metabolites of progesterone called pregnenolones, which are what the newer treatments for postpartum depression are all about and focused on. And I hope that this talk helps you understand that a little bit better and why those are useful and how to access them in the treatment of women with especially postpartum depression. But before we delve into that, let me just say a word about thyroid, and for especially those non-medical, or sometimes this isn't part of standard care, but it should be. In standard practice in women's mental health, we must screen for thyroid disease by measuring thyroid hormones. In the blood, they can be measured TSH, free T3, and free T4. And in perinatal mental health, we add the screen for thyroid autoantibodies, which is a measure of autoimmune disease when a woman is suffering from autoimmune thyroiditis or Hashimoto's thyroiditis, which are synonymous. This is important because it's well established that a woman with thyroid disease, especially autoimmune thyroiditis and or Graves' disease, women with these illnesses are prone to dysregulation of the thyroid and inflammation during the peripartum, so in pregnancy and postpartum. And we know, well documented, that this leads to more severe postpartum psychiatric illness, particularly as it relates to postpartum psychosis. So an important pearl here is, whether you're a medical or non-medical provider, is that there are guidelines for monitoring the thyroid in women with thyroid disease in pregnancy and the postpartum. And sometimes we have to help our patients advocate with either their OBGYN or endocrinologist to keep them well by following these guidelines. And those guidelines were updated in 2017 by the American Thyroid Association. And you can find those just by Googling it as an aid to help you guide your patients in the right direction. And then, like we talked about, using hormonal treatments sometimes to even prevent or early intervene or prevent severity. And so the key take home message here is that we have to treat the thyroid disease and the psychiatric illness concomitantly, or we cannot maximize her recovery or healing. Next slide, please. Lena, next slide, please. Yeah. Let's see if this is the one I wanted to mix up. No, this is the one. That's right. I wasn't sure if I wanted to switch it around. So estrogen and progesterone have an integral part to play not only in reproduction, but in brain plasticity by interacting with neurotransmitters or neurons like serotonin, norepinephrine, and dopamine, as well as something called GABA and glutamate. So this is pretty scientific, but bear with me. It's just going to help you understand some basic clinical facts. So we all know serotonin, norepinephrine, and dopamine because they have become well known because of their role in the therapeutics effects of antidepressants and because on social media and Instagram, everybody seems to want more dopamine, right? Everywhere you look, dopamine, something about dopamine's out there. But GABA and glutamate have become more on the scene in the last decade. And GABA in particular is known to be important in perinatal mental health because it's what's called a neuroinhibitory hormone or neurotransmitter. It promotes things like stable mood, calm, and sleep. For example, benzodiazepines like Xanax, Klonopin, Ativan, lorazepam, alprazolam, clonazepam work through enhancing the GABA system. So no wonder they can have a role in postpartum anxiety and panic. And this slide is a little busy, but I ask you to focus on estrogen, which is in the green, and progesterone, which is in the orange, and look at some of the things that they do. So the green of progesterone enhances transmission of GABA. So it's really the metabolites of progesterone that do that. And estrogen acts as a natural antidepressant. It inhibits the breakdown of serotonin, norepinephrine, and dopamine. It actually influences the firing of those nerve cells to keep those balanced. So here we can see the importance of those hormones and really a complexity in how they work in the brain. So next slide, please. Oh, this is where I wanted to switch it. Go to the next one. And then, oh, no, wait, we're missing one. Go to the next one. That one. Okay, we're going to back up after that. So we've come to understand something called hormonal sensitivity in women with mood and anxiety disorders or those with PMDD or perinatal illness. And we've come to understand that as women who have brains that are sensitive to shifts in hormones, which has largely been thought of as the hormone withdrawal hypothesis. Some have suggesting it, labeling it as hormone sensitivity syndrome, because that's how significant it can be in altering a sense of well-being. In reality, it's not too much or too little, or just withdrawal of hormones, but a sensitivity to change of hormones, especially if it's a steep change. The brain, and I often tell women this clinically, the brain likes slow and steady and rhythmic. In animal studies, also, we've proven that withdrawal of estrogen leads to despair and anhedonia, and concurrent withdrawal of progesterone has added symptoms of learned helplessness and anxiety. So remember, estrogen more on the depression side, progesterone not only on the mood side, but also on the anxiety side. So clinically, this is where history taking is important in reference to understanding hormonal sensitivity. So especially prior to pregnancy and assessing peripartum risk. So was the onset of mood and anxiety symptoms or even subclinical symptoms within a year of her first menses is something we always ask. This is often a retrospective recall question that she may never have been asked before. Does she suffer from PMDD? Is she one of the 50% of women who cannot tolerate contraceptives physically or emotionally? Is she coming to you after previously suffering perinatal psychiatric symptoms? If hormonal sensitivity is identified, remember it's important to follow her symptoms as they relate to the hormonal changes per trimester in pregnancy. Because remember, the brain likes consistency, and when there's irregularity in first and third, that's when she may be the most vulnerable. And if we even just share with her that she may see bumps in the road during those times, or that we monitor per trimester, we can have more focus on keeping her well. So clinically, in simplifying this information, if the brain likes rhythmicity and predictability and dislikes when hormones are rapidly changing, so go back for me. Sorry, these are out of order. The one before that. So this brings us to look at the hormonal changes during a menstrual cycle on the top, and hormonal changes during pregnancy and the postpartum are the bottom. And what's important to note here is in PMDD, it makes sense that when estrogen is on the downslope, the blue, and I don't know if you can see my cursor, and progesterone is on a steep upslope, which is 7 to 10 days before the period, that's when women are most likely to experience PMDD, hormonal sensitive women who may be at risk for what we all know next in our field. We all know that hormones fall off a cliff at delivery, as depicted in this graphic. You can see where birth is, and you see the sleep, like literally a cliff where the estrogen, particularly in progesterone, fall off. And that's why 80% of women experience the baby blues, we believe, is somewhat a trigger. And that can also sometimes be a trigger for postpartum depression. Regarding the biology of oxytocin, because we said we were going to mention that also, it can be stabilizing because it enhances dopamine. So in reference to hormones, we encourage oxytocin enhancing behaviors like skin to skin, like breastfeeding, like skin to skin, not only with the baby, but also with your partner, or with other children in the home. So we know that oxytocin and dopamine kind of go hand in hand. We also know from studies that women who have low oxytocin in the third trimester, there's an association with increased depressive symptoms during pregnancy and early postpartum. And low oxytocin in mothers correlates with low oxytocins in fathers and children in the same family. So we should encourage not just talking about biology and hormones and medications, but everyone in the family should be touching and dancing, is what I say. So, with this information regarding fluctuation in hormones, especially the hormone withdrawal hypothesis, how do we apply that clinically? So there are small studies with good outcomes utilizing estrogen supplementation by mouth or in a patch immediately postpartum to offset the cliff that drop that rattles the brain. But estrogen can increase blood clots, it can decrease milk production, and those studies are really small, like 30 to 40 participants, and it really hasn't taken off as a treatment. You may also ask, why not give oxytocin? Because we all want more oxytocin and dopamine. But those studies haven't really panned out either. Figuring out how to administer in a way that it's bioavailable and the blood-brain barrier and all that has been a challenge. So we don't do that either, and that's why we recommend those non-pharmacological things. So what do? We give SSRIs, because when the brain gets rattled and the hormones shift at delivery, serotonin and norepinephrine and dopamine become unstable. And over time, SSRIs, remember 4 to 6 weeks or so, can provide balance and give relief from the postpartum depressive symptoms. And that's also when we give sometimes short-term agents like the benzodiazepines to utilize GABA in balancing and giving calm and sleep until the SSRIs kick in. So now you're going to have to go 2 slides forward, I think, please. That one right there. Okay. More recently, research is leading us to more in-depth understanding of the variability of hormonal sensitivity as it relates to genetics and the metabolites, as I mentioned, of progesterone. So just real quick, for those also who are non-medical, when we talk about a phenotype is an observable characteristic based on the expression of genes. So hormones, most commonly associated with reproductive psychiatric disorders, we are learning are descended from the metabolites of progesterone. You may have heard the term pregnenolone, isopregnenolone, or allopregnenolone, all of which have a direct effect on enhancing GABA, as we saw in the diagram. Remember, calm, mood stabilization, and sleep, which we want to give all women and protect in the postpartum. Also, pregnenolones influence stress response and emotional regulation. So here comes some really exciting, more recent research that's in the third paper on your references that I encourage you to access. Regarding phenotypes, there are women without depression ever before, prior to pregnancy, who develop postpartum depression. And they have been found to have a key defect in the progesterone metabolite pathway, meaning their ability to break down progesterone to the pregnenolones that are the one that give us the most GABA enhancement. There's a defect. If identified, these women, it may help us predict who's going to develop it later. The findings in these recent studies could lead to a blood test that may predict postpartum depression and identify women who may benefit from prophylactic treatment. Like, we're really close to that, and this is very exciting. Dr. Osborne, in her research and the paper I reference, found that with lower pregnenolone to progesterone ratio and elevated isopregnenolone to progesterone ratios during the third trimester, those women were more likely to develop postpartum depression. So again, pretty exciting stuff. I'm going to give you examples of how we may see this clinically and how I've seen it in my practice and how it informs treatment. So if we are treating a woman who reports worsening of postpartum anxiety and mood symptoms after a period of stability, or has new onset with no apparent psychological or other risk factors that are notable, it is important to screen for whether she was prescribed the mini pill, a progesterone-only contraceptive commonly given to breastfeeding women, which contains a form of progesterone hormone called levonorgestrel that can be destabilizing to natural pregnenolones. Has she, which has become prominent, the standard of care, common practice, has a hormonal IUD been inserted at 6 weeks? Those are progesterone-based IUDs. And although we are told that they don't have appreciable systemic absorption, there are some women who are sensitive to both of these progesterone agents, and we have to kind of work backwards in that screening and help her in decision making about what type of contraception she may use that's not so destabilizing, especially in the early postpartum. And women with that genetic defect that Dr. Osborne talks about are probably the ones that we're seeing in our offices and may be more prevalent than we realize. So let's got to move forward a little bit. Next one. Okay. So in our little 20 minutes, this, I hope, has set the stage for you understanding why the newer treatments for postpartum depression, specifically Zulresso and Zurzuvae, can be effective. They are synthetic forms of allopregnenolone. So they strongly influence GABA, which is why the primary side effect of sedation and somnolence led to these medications being classified as controlled substances. So they're not addictive, but they're classified as controlled substances because some women become so somnolent from the GABA effect short term that they need help in caring for their babies, and they really just need to sleep, which we know is restorative in the postpartum. Unfortunately, because it's been categorized as a controlled substance, it makes it a little more laborious in getting access. Any of you who have tried to get it, in my experience, it's so many loopholes and red tape before you can get it. It usually takes 1 to 2 weeks. But it also can be very effective. And women who have this defect in the metabolic pathway for progesterone probably will respond a little more robustly to these treatments than those who don't. But it does seem that in general, there is a pretty good outcome and positive response. And even in psychiatric medicines and medicines in general, there's always that little qualifier that says we don't really understand the mechanism of action, which is similar to this, but we do understand very much how the pregnenolones affect the brain during this highly vulnerable hormonal period. But even though the earlier studies and more recent show that the pregnenolones can help women go into remission, keep them well for up to 30 to 90 days, we also always keep that antidepressant on board, just because we just want to keep her well and give her the safest, most effective treatments in that early time. So I think with that, I'm happy to take questions or participate for a little bit in any case presentations. Sorry, I thought I spelled references wrong, but I think somebody fixed it for me. Thanks. Yeah. These are 3 really good papers. Even if you're non-medical, I would recommend that you consider accessing, especially with all the good stuff on the horizon related to understanding genetics and hormones and in treatments. Thanks.
Thanks, Dr. Bruner.